Functional appliances. This presentation is about functional appliances, and it will include introduction, mode of action, indications for the use of functional appliances, byte registration for a functional appliance, classification, and common appliances. Skeletal problems in orthodontics can be treated either by growth modification, orthodontic surgery, or by camouflage. How to choose between these three options depends on the skeletal growth status of the patients and the severity of the malocclusion. Functional appliances are a group of orthodontic appliances that have no active components, such as springs, elastics, or screws. Instead, they use the forces generated by the masticatory and the facial musculature. They use these forces to change the skeletal relationship between the upper and the lower jaw. Functional appliances commonly used to correct class 2 or to treat class 2 malocclusion. So they are used to reduce the overjet. So the purpose of the functional appliance is to change the anteroposterior relationship between the two dental bases. How they act, or the mode of action. Functional appliances achieve their effect by positioning the mandible forward, causing stretching of the facial musculature. The purpose is to change or to correct the anteroposterior relationship. So, this stretching of the facial musculature will generate forces which are delivered mainly to the teeth. So, they act posteriorly on the upper arch and they act anteriorly on the lower arch. These forces produce or result in skeletal effects and dental effects. But our aim, because the purpose of the functional appliance is to do growth modification, so our purpose or our aim or our objective is to maximize the skeletal effects and minimize the dental effects. However, we cannot do this. Any functional appliance will result in some skeletal effect and some dental effect. What are the dental and the skeletal effects? First, starting with the skeletal effects. The mandible and the maxilla are affected. Both are affected. The mandible, the effect on the mandible is stimulation and enhancement of the mandibular growth. The effect on the maxilla is restraining to the maxillary growth. Both are favorable for correction of class 2 malocclusion. Okay. What about the dental effects? The dental effects include distal force on the upper incisors, mesial force on the lower incisors, and vertical effects on the anterior and the posterior teeth. The distal force on the upper incisor will cause retroclination of the upper incisors. The mesial force on the lower incisors will cause proclination of the lower incisors. The vertical effects on the anterior and the posterior teeth will affect, or the vertical forces on the anterior and the posterior teeth will affect the overbite and the vertical dimension of the face. And we will see later on how to manipulate these forces. Okay. From what we have discussed previously, we can conclude the indications for the use of the functional appliances. The first indication is jaw discrepancy, which means skeletal malocclusion. Mainly, functional appliances are used in class 2 due to mandibular retrusion. The patient is still growing and the patient is well motivated. Definitely, especially with the removable appliance, we need motivated patient. Which is the best time to use the functional appliance? Which is the best time to insert or to construct a functional appliance for your patient? The timing depends on the skeletal status of the patient, the skeletal growth, timing of the dental developments, which means the dental age, and also the chronological age do not correlate properly with the skeletal growth. So we need to determine the skeletal growth status of the patient. We discussed this before in the presentation for diagnosis or examination for the orthodontic patients, and we discussed how to use the hand wrist X-ray to determine the skeletal growth status of the patients. Functional appliances would be more successful if used during the adolescent growth spurt. To construct removable functional appliance, you need bite registration. How to take the bite registration for a functional orthodontic appliance? It's basically similar to what you do in orthodontics when you do bite registration. But here, we need to advance the mandible to the desired position to correct the class 2 malocclusion. During bite registration, you need to consider the following. In case the overjet is too large, forward positioning is done in 2 to 3 stages, which means that you may need more than one appliance for the patient. You will correct the large overjet on stages. In case of forward positioning of the mandible by 7 to 8 millimeter, the vertical opening should be slight to moderate, which means 2 to 4 millimeters. This type of activator is called horizontal activator or H activator and is indicated in deep bite cases. With this appliance, we can manipulate the over-eruption of the posterior teeth. We allow over-eruption of the posterior teeth, which will decrease the deep overbite. If the forward positioning is not more than 3 to 5 millimeters, then the vertical opening can be 4 to 6 millimeters. This type of activator is called vertical activator or V activator or Harvold activator and is indicated in open bite cases. The large vertical opening causes intrusion of the posterior teeth. This intrusion will close the bite. Okay, so now we will talk about the types or the classification of the functional appliances. Functional appliances can be classified to removable functional appliances and fixed functional appliances. Each one has its advantages and disadvantages, and we will discuss this later on. But functional appliances can also be classified to tooth-borne appliances and tissue-borne appliances. Teeth-borne appliances could be passive or active. Passive are appliances that do not include active component, like what we said in the introduction or in the definition of the functional appliances. We said they are group of orthodontic appliances that do not include active components. However, they can include some active components like a spring or a screw, and in this case it is defined or it is called active functional appliance or active tooth-borne appliance. The other category is tissue-borne appliances, and the only appliance under this category is the functional regulator or the Frankel appliance. It's the only appliance under this category. All other appliances are under the title or the category teeth-borne appliances. However, they are fixed or removable. So teeth-borne appliances could be active or passive. Tissue-borne appliances only include the Frankel appliance. Teeth-borne appliances, example of the teeth-borne appliances are the activator, the bionator, herpist appliance, which is a fixed functional appliance. Okay. Now we will discuss some of the fixed appliances or some of the functional appliances, the common functional appliances used in orthodontics. The first one is the activator. The first activator was designed by Anderson in 1908. And it can be described as upper and lower acrylic appliances fused together. Upper and lower appliances fused together. And this design is called a monoblock design. So it's a monoblock design. It could be passive, which means it does not have or does not include any active components, or could be active, including springs like this one in this slide. It includes a spring to move the molar, the first molar tooth. So in this case, it's an active activator. The activator has no clasps because the intention, as we used before, is to use the muscle, the forces of the muscle, the muscles, the facial muscle and the muscles of mastication. So the intention is that the looseness of the appliance in the mouth causes the patient to bite on it, activating the muscles. And this activation or this stimulation of the muscles is the factor that will generate forces that will be transmitted to the jaw and the teeth. The other type of appliance is called functional appliances is the bionator. The bionator can be described as a cut down activator. So it has a minimal, that its main advantage is that it has a minimal bulk of the acrylic, which makes it easy to wear. So you notice that the part of the acrylic in the palate is removed. So the acrylic is cut down. It could include coffin spring to expand the maxilla. Sometimes we need to expand the maxilla in class 2 cases, class 2 malocclusion, especially class 2 division 1, because the arch is tapered or V-shaped. So sometimes we have crossbite, posterior crossbite, and we need to correct or to expand the maxilla so we can add coffin spring to the bionator. We have also buccal extension, which forms buccal wire shields. These buccal wire shields hold the cheeks out of contact with the teeth, and this also helps in expansion. A different functional appliance is the twin block. The twin block introduced by Clark in 1988. And this one is different than most of the functional appliances in that it is constructed in two parts. It's not a monoblock design. So it's constructed in two parts as separate upper and lower appliances. Upper and lower appliances. This made this appliance popular between the orthodontic patients. It is highly acceptable by the patients because eating and speaking function in general is easier with the Clark or with the twin block appliance. Forward positioning of the mandible achieved in this type of appliance by the lower blocks engaging in front of the upper. The appliance incorporates interlocking inclined planes. These interlocking inclined planes will guide the mandible forward till it engages in the upper arch or in the upper part of the appliance. So the activator, the bionator, the twin block are all removable tooth-borne functional appliances. Now we will talk about tooth-borne fixed functional appliance. The common example is the Herbst appliance. Herbst appliance is described as bilateral telescopic mechanism. It is constructed of pen and tube. So there has two parts, pen and tube. The pen fits into the tube, guiding the mandible forward. So this design keeps the mandible in continuous anterior position. This continuous anterior position by any of the functional appliances stimulates the muscles, the masticatory muscles and the muscles of the face, as we said before, and also reduces the pressure on the condyle. So also stimulating the growth. Fixed functional appliances in general have their advantages. These advantages include the appliance works for the 24 hours. It's always there. Because of this, it does not depend entirely on the patient cooperation, as is the case with the removable functional appliances. This is one advantage. Another big advantage is that functional appliances shorten or reduce the treatment time. Treatment time for any removable functional appliance is about 12 months, 1 year. But with the use of with a fixed functional appliance, it could be reduced to 6 to 8 months. 6 to 8 months. This is big advantage for the patients and for the orthodontist. However, fixed functional appliances also bear their disadvantages. They are expensive. They are liable to fracture or breakage. Lateral movement is restricted with this type of appliance. And because of this restricted movement, it's difficult to tolerate by the patients. So it's not all. Herbst has its advantages and disadvantages. So Herbst appliance is a fixed tooth-borne functional appliance. So now we will talk about the only tissue-borne functional appliance, Frankel. It also acts to change the muscular and soft tissue environment of the jaw, and therefore modify the growth. Frankel appliance includes acrylic components and wire components. This lingual part is called lingual bed, and it's the component that guide the mandible to the forward position that is desired to correct the overjet. So this lingual bed, acrylic part. Another acrylic part is the lip pads, and the lip pads allow forward development of the mandibular alveolar process because it removes the forces coming from the lip on the teeth. In the same way, we have buccal shields, acrylic buccal shields. These acrylic buccal shields facilitate posterior dental expansion because also it removes the forces coming from the cheek on the teeth. So we have three main acrylic components: lingual pad, lip pads, and buccal shields. The wire components include short labial arch, and it acts to retrocline the upper incisors. And this is also retroclination of the upper incisors is advantageous to reduce the overjet. As we said before, functional appliances are mainly used to treat class 2 malocclusion due to mandibular retrusion. But they can be used also in class 3. So we have modifications of the Frankel appliance. Frankel appliance 1 or FR1, it is used for the treatment of class 2 division 1, and it's the design that we explained in the previous slide. Frankel appliance 2 or FR2, it is used for treatment of class 2 division 2 malocclusion. And this design incorporates, in addition to the regular components, a palatal wire to procline the upper incisors. So it is used in class 2 division 2 cases. In class 2 division 2 cases have a characteristic feature which is retroclination of the upper incisors. So we need to procline the upper incisor. This palatal wire will help to procline the upper incisors. Functional or Frankel 3 or FR3, it is used for the treatment of class 3 malocclusion. And here we can see a different design than the previous one. In FR3, we have lip pads labial to the upper incisor to procline them, to allow them to procline, removing the force coming from the lip. So we have also lower labial arch to retrocline the lower incisors. Both proclination of the upper incisor and retroclination of the lower incisors will help to correct the class 3. Both proclination of the upper incisor and retroclination of lower incisors are advantageous for correction of class 3 malocclusion. So the effect is mainly dentoalveolar, as we said. Okay. Any functional appliance, removable functional appliance, is worn about 14 to 16 hours per day. This includes all the removable functional appliances. And the patient can use the bedtime in addition to some extra hours to complete the 14 or the 16 hours. Before inserting any appliance, functional appliance or removable functional appliance, you have to check it on the cast first. You have to make sure that there is no sharp edges, broken wires, or anything. Everything is okay. And it is recommended to use gradually, which means that you ask the patient to wear it in the first week for just few hours, and then gradually increase the hours till you reach the 14 or 16 hours.